TopMedTalk.
Welcome to TopMedTalk. This piece comes from our live coverage of Anesthesiology 2022. It is the single largest gathering of anesthesiologists in the world and the annual meeting of the American Society of Anesthesiologists. Now, our live coverage is available now at live.topmedtalk.com. More details in the show notes. Don't forget to subscribe, and please help us boost our signal by sharing this podcast wherever and whenever you can. Well, hello and welcome to TopMedTalk. We're at Anesthesiology 2022 here in New Orleans, Louisiana at booth 2245. Now, I'm Desiree Chappell, and I'm joined by my co-host, Professor Monty Mythen. Hello, Monty.
Desiree, great to be here.
It is wonderful to be here. So, fifth year for TopMedTalk at Anesthesiology.
At Anesthesiology, yeah. And in between a couple of odd ones, because we talked about earlier because of COVID.
Yeah.
But we are back to what feels like normality. It feels like normality. Yeah, normality.
Yeah, I think so. Now, Monty...
Bit of hand sanitizer just crept on.
Normal-ish.
Well, we've been doing a lot of handshaking today, so the hand sanitizer's coming back out.
That's right. There was actually a lot more handshaking.
Handshakes have returned, yeah.
We need to maybe go back to bumping.
Too. I'm a hugger, so. Well, TopMedTalk is here at Anesthesiology 2022 in the exhibit hall. It's been a phenomenal meeting so far. We've already, it's just started. We've had great conversations. This next one's going to be no different. Before we get started, though, I did want to take an opportunity to thank our sponsors to support TopMedTalk. Now, we are a free global perioperative podcast that we disseminate educational information to the world. And without this generous sponsorship and support, we couldn't do it. So Edwards Life Sciences, Medtronic, some of our platinum sponsors. But really, this year, the American Society of Anesthesiologists, they've done everything for us here and given us this boost. So thank you to them for sure. Now, if you are listening to this on the podcast and you are still within the time frame of October 22nd through the 24th, you can get on our live stream. It is free to the world. It's live.topmedtalk.com. And you can hear all of our phenomenal conversations throughout the entire weekend at that site. It's live.topmedtalk.com. You can see the schedule. So look for all your favorite presenters who are here at the meeting presenting during the weekend. And check it out. Now, you also have a link that takes you to the EBPOM, the Evidence-Based Perioperative Medicine Educational Hub. Monty?
So the EBPOM Educational Hub is where we broadcast all of the, aside the podcast, we also, all of the lectures that we record from our meetings around the world are all put there so you can view them again. And we've now accumulating hundreds of them over years of doing EBPOM, and many of them, depending on your constituency, are linked to CME CPD points that are still available. You can actually get, if you, in the UK, for example, you can get your full year's CME by watching ebpom.org.
Yeah, that's right. Absolutely. Well, we want to start off this conversation. This one is actually really exciting for Monty and I. It is getting the group back together again for a presentation that was given earlier this morning. It is the pragmatic validation of the ASA, American Society of Anesthesiologists, Intraoperative Hypotension measure. And this is a group that we have formed as a collaborative through a couple different organizations. So I'm going to bring everybody in. We'll talk a little bit more about that. But we have Dr. Rick Dutton, who is a fan fave for TopMedTalk.
Rick the man.
It is Rick the man. That's right.
I have had an unfortunately diverse career, yes, which lends to that. I am a Chief Quality Officer for U.S. Anesthesia Partners is my day job. Yeah. And practicing anesthesiologist in Dallas, Texas.
Yeah, and Rick actually has been on TopMedTalk several times, and you can hear all of the podcasts that he's done at topmedtalk.com. So just a plug for all your work that you've done. Next to Dr. Josh Lumbley, my partner in crime.
Yes, Desiree. Hi, good to see you. First, compliments to you, Desiree, for rolling that R and calling it New Orleans as opposed to New Orleans, or as some of your folks may call it New Orleans. No, not acceptable. New Orleans. So nice job. So I'm Josh Lumbley. I'm an anesthesiologist from Columbus, Ohio, and I'm NorthStar's Chief Quality Officer.
And my partner in crime, I am Vice President of Clinical Quality for NorthStar. That is my day job.
Yeah.
My many hats. And then Dr. Wael Saasouh. Well, thank you so much for sitting down with us.
Thank you for having me. I'm Wael Saasouh. I'm an anesthesiologist at the Detroit Medical Center, and I'm the Regional Director for Research for NorthStar Anesthesia.
All right.
Desiree, because I'm guessing not everyone knows, you might be about to go there, but to me, a NorthStar as a sailor is something you find in the sky in the Northern Hemisphere to find. And I kind of think a US anesthesia partner is, we're all partners, aren't we? What are these things you're talking about?
We are, golly, if we were going to be a collective, we'd be large group practices,
Okay.
which in the U.S. anesthesia environment, these are private practices that have become multi-city. So every anesthesia group start traditionally in one building. One anesthesia department, one hospital, one bunch of surgeons, one building. Now, obviously, the hospitals have metastasized, so now they have surgery centers and non-operating room suites and stuff. So you do that. Maybe if you're in a big city, you might start picking up some work for different systems or different hospitals, and that's happened. And then at some point, you become a national company.
So how big is USAP?
USAP is about 5,000 clinicians right now, about half anesthesiologists and half anesthetists, CRNAs and CAAs. And we cover hundreds of hospitals across the United States.
And NorthStar, John?
Yeah, we're about 2,800 anesthesiologists and nurse anesthetists across 22 states.
Wow.
Yeah.
That's a country.
It is a country.
Between the two of you.
Well, this collaboration that we have, and Rick, maybe I'll let you go into it a little bit more, but it is truly unique because as two large independent organizations sitting down together on the same stage, but also working together in quality, really in the vein of quality, is pretty unique.
Yeah, quality should be free, right? We all get out of bed in the morning trying to do the best for our patients, trying to advance science. So collaborating on things like this is honestly good for both our brands, but it's good for our patients.
Yeah.
And fundamentally, we did this research because we could.
Yeah.
I guess is the way I'd put it.
You're competing business entities.
Yeah.
Correct.
Yeah.
So in the United States, a hospital needs an anesthesia provider, and they might put that up to bid. RFP is the term of art, a request for proposals to provide anesthesia service there. And yeah, we compete. Sometimes bitterly.
Yeah, yes. And regularly, especially for large practices. I would just also say that the nice thing about this is there is a perhaps incorrect opinion that large group practices really only provide a service which is staffing anesthesia. Quality of anesthesia being an asterisk associated with that. But that research is like long and gone. And research falls strictly to academic departments, and that if you join a large group practice, it is strictly about the practice of anesthesia, not really about pushing the science. And I think that's the other thing that's kind of pretty unique about this collaborative that we've got here.
So you're a collaborative that's just presented early in the opening of the American Society of Anesthesiologists on the main stage about research you did together.
Correct.
Yeah.
Tell us more.
Well, actually, you know what, while you haven't talked much, can you walk us through just a little bit of what we were looking at?
First of all, this is such a unique opportunity because for the business side where USAP and NorthStar are working against each other, in quotes, for the research and the science, they're working together. And that's where my part was. I'm coming in from a research angle. I think it's an amazing opportunity. I think it's something we need to do more.
Yeah.
Now, along those lines, what we did was we reviewed records of over 120,000 patients from both practices across multiple states and multiple hospitals and multiple providers. And the point was to look at hypotension that happens intraoperatively in the operating room. And we wanted to see, at least as a first step, how often does it happen? What does it mean? What are the risk factors for it happening? Just to sort of have a bird's eye view of what's going on in the non-academic setting. Because most of the studies that have been out, everything that's been published is mostly major academic centers. They have a certain structure to how they perform anesthesia. They have a certain structure to their pre-op and post-op areas. This hasn't been as explored, if at all, in the private setting or in the community setting. So that's where this came about, and it's become a major project where we only started to report what we're finding, and it's just right now we're just looking at incidences, but we're starting to collect more data and to correlate that with other outcomes.
So when you started the journey, because there's already been, as you say, quite a lot published from academic centres, in other words, university associated, or sometimes called the ivory towers. Did you expect you'd find more or less intraoperative hypotension, or about the same? Take turns, because we don't think we discussed that together before.
Yeah.
Well, why don't you go first? What did you expect?
Sure. It was hard to say what to expect because
Okay. You've got to get off the fence there. What did you?
Sorry, you got to choose one or the other. Wow.
For
You
the
should be a
most part,
politician. We have people like you in the UK running the country.
I run away from politics as much as I can.
Go for it. Which one?
In a way, we were looking at ambulatory surgical centers, private practices where typically you get to send the healthier patients. You tend to have the smaller procedures, things that can happen over a single day that patients can go home. So in a sense, we were thinking those were healthier patients. Personally, I thought we were going to find a lot less hypotension.
Oh, there we go.
I actually thought we would find less as well, just given that we're talking about shorter cases and non-academic center cases.
Yeah. So the straight up prediction: healthier patients, less hypotension.
I knew some of the what types were coming from some facilities, and I kind of thought it would be around maybe even a little bit higher in some instances.
Okay, so we've had our teaser. More of the story. Let's get it out there.
So we're talking about intraoperative hypotension. I think we need to level set just a little bit. We were looking specifically in within the study about the IOH measure, the E-pre-op 31 measure, correct? And that was how we identified IOH, or how we defined IOH, right, Rick?
Yes. So one of the things that's controversial is, what do we really mean by hypotension? And there are multiple definitions out there in play. We picked, for simplicity, the ASA's definition of it, developed by E-pre-op, now Provation, which is a cumulative 15 minutes with a mean arterial pressure below 65. And there's some framing around that, so it has to be a real operation, general anesthetic, lasting at least an hour. And if you add up to 15 minutes with the MAP below 65, that counts as ticking that measure.
All right. And Josh, what did we find in our results?
Yeah, we found that, so basically the results came out that large numbers of, what was it, 2/3 of our patients, 2/3 of our cases, I'm trying to recall this from memory, 2/3 of our cases were ASA 2s and 3s, and roughly 2/3 of our cases also were 2 hours or less. And we found amongst those cases, or amongst in total, that 29% of our cases qualified as having, as ruling in, as having, a cumulative period of intraoperative hypotension of greater than 15 minutes.
So quarter of an hour.
Yes.
Below the map that we're telling each other we should try and stay above.
Yes.
Actually, worse than that if you look at it differently, because in that 29% that had at least 15 minutes, the average amount of hypotension was about half an hour.
Yeah. 32 minutes. And again, understanding that even worse than that, being that 2/3 of our cases were less than 2 hours in duration. So, we're talking about the cases that are affected are a significant percentage of the time. During those cases, a patient was hypotensive.
And while I can imagine lots of people sitting here thinking, why are you bragging about how bad you are? Because it's not.
Wait, I said this was going to be good for everybody.
It's not inconsistent. What you basically found is something that's not inconsistent was reported in high-risk patients in major centres before. You've just gone to different places and found that it's all over the place.
Correct.
It's not inconsistent, but it's more surprising that it should have been. And I remember when we were presenting this morning, when we said that 29% number,
Were there gasps?
I saw faces that were in shock because you wouldn't expect it. We started off thinking healthier patients, they should be fine. Most of our patients are less than 65 years of age. Most of them are ASA 2s or 3s. Most of the cases are a couple hours long. We tend to intuitively dismiss those cases as not at risk. And to find that about a third of them are getting hypotensive enough to qualify for a measure that's a quality measure, then there's something to look into there. And it's not something that we were considering much before we started getting those results.
And that's the same in an ambulatory, what we call the ambulatory surgery centres or day case anesthesia. You kind of think you go in and get out quickly, you must be okay.
Actually, if you isolate the ambulatory cases, it's slightly more. It's even 31%.
Okay, so but they all seem fine. They're all going home, aren't they? I mean,
That's what we think.
Yes, and out of our sight. And it is the big problem in anesthesia quality improvement is we leave the patient in the recovery room or in the surgery center, and we leave the building. We have no idea what happens next.
Yeah.
So Desiree, as a part of the quality team as well, I'm going to interview you for a little bit now.
Oh.
So some of the things that keep getting reported are this myocardial injury and this acute kidney injury. And what we've learned to understand is neither of those things hurt and you can't see them.
Right.
So they're silent abnormalities.
Yeah.
Is there any suggestion that this is going on in those other places? This sort of...
Yeah, I mean, and it is the black box of what we do. And I think from a quality perspective, we have been flying blind, quite frankly, for a long time. And so we know that what we do in anesthesia affects outcomes. Now, what we haven't completely, connected the dots, at least in our data set, is the rate of hypotension that we had and the hypotension that we had. How did it affect outcomes? And that's what I'm really hoping that we can take a look at to help give more visibility into that, so we can go back to our anesthesia providers and say, look, it actually does make a difference about what you do.
And Rick, what outcomes do you think are worth looking at? Which dots do you think we can connect?
First, I'll say provocatively that we may solve the problem before we know the answer.
Okay.
Yeah,
I'll come back to that.
Yeah.
But the hard data points we should be looking at are individual patient acute kidney injury, which we can measure very precisely now, so rise in creatinine post-op and markers for kidney function post-op. Same for the heart. So again, biomarkers, troponins, things like that, but then MI, stroke, that kind of thing. And then a brain marker.
Okay.
And so cognitive function, very difficult to nail down post-op because you kind of got to know where you start from. So it's a hard problem, but measures of cognitive function would be in there as well. So post-operative delirium, that kind of thing. And then one of the questions we got this morning was the gut. Are you going to bring that up? Go ahead.
I was literally thinking the exact same thing. And Monty, you brought it up, was just gut perfusion. And that can manifest itself as post-operative nausea and vomiting. And, which is something that specifically in the ambulatory population, we perseverate on tremendously, and we treat with medications. Oftentimes, without looking at the entire perspective, again, I'm going down the garden path of this causes this, but it is an interesting question of hypotension and gut perfusion manifesting itself in postoperative nausea and vomiting.
Because if we, and we've talked about this a lot, but if we just go after the no intraoperative hypotension, there are smart ways and less smart ways to avoid hypotension. So we kind of got to connect it to something else. So my favorite is no IOH, no AKI. Because if you've got a beautiful anesthetic chart. Now, the trouble we got, Rick, is there's people, other people get their mitts on that in between leaving us and measuring the creatinine.
And so team-based or bigger picture measure, when I talk about solving it before we know all the connections, one way that could happen is to take it to the next level of metrics. So what happens when you have AKI? You stay in the hospital longer.
Yes.
You're more likely to have an infection. You have more other risks. You become a more expensive patient. So right there are three big markers that we could jump to those endpoints and say length of stay. I mean, you think of how much work's been done in enhanced recovery by you, among others, and talked about here. We don't know what part of enhanced recovery makes the length of stay 2 days shorter.
So we heard in our EdPom London meeting, you can watch the presentation by Professor Guy Ludbrook on our platform. He presented the early results of them embracing the whole recovery period. So Team Anesthesia did no intraoperative hemodynamic instability and then kept the patients. This is a major Australian cancer centre, so the big surgeries. They kept them for the first overnight stay, and they managed those patients, and they went a year with no AKI. So they said they had one, But the one was a night they had a traveller on who didn't follow their protocol. So they're going to say, we really had one. But that's different to when we had 20%, 15%, 10%. So if they can go to none, and I know I keep banging on about this, that means it's iatrogenic. That means it's avoidable.
Absolutely.
Avoidable.
Absolutely.
Is that fair?
Yeah.
Agreed. Okay, let's go do it. Right.
Yes. and then the other thing about solving it before we understand all the parts of it is I'll just believe intraoperative hypotension's bad. I trust Dr. Sessler. I trust all the prior work done in this area.
But don't just fix it with a phenylephrine infusion.
That's right. That's right.
That's
Yeah,
bang on.
So as a quality improvement project, maybe I have all the evidence I need to go change practice.
Yeah. I mean, maybe you can fix it with just a phenylephrine infusion, providing you've made sure that you've got a little bit of fluid on board before you stop. But, we've seen it before and we're seeing a bit again. The unintended consequence of saying we're just going to fix, beta blockers slow your heart. Slow hearts have less heart attacks. Right. Let's give beta blockers. Oops.
Yeah, exactly. Well, and I mean, one of the uphill battles since all of this has been coming out is that people do go directly to a phenol infusion, which would be okay, except now all of our US protocols say fluid restriction and to not give as much fluid.
Where did that creep in? Because the original ones never said that.
We talked to Brigitte Brandstrup this summer, who actually coined that term. I can't talk. Coined the term fluid restriction in our space, but it was deranged. It was never intended like that. So I would listen to that conversation.
Said, avoid fluid excess.
Yeah.
Like, don't drink too much is not the same as don't drink at all.
Yeah.
You see what I mean? Like,
so, I mean, I can see where now we are, struggling a little bit because they're putting phenol we are putting phenol infusions on, but in an empty tank, which is bad.
Yeah, which would be bad.
Yes.
Correct.
Right.
So there's a lot of pieces to this.
A lot of pieces. Yeah.
And I hope that over time, further analysis of our data, which is underway, and further science, other people studying it, will connect more of the dots. But maybe we don't. We should do everything in parallel. So at the same time, we should be trying to solve the problem.
So it's probably more like you raised it earlier, line-related infection. We used to think getting blood-borne MRSA infections were normal. Now we regard them as a never event.
Yeah.
Everyone, from the first person who gets involved, everyone's got to wash their hands.
Yes.
Everyone's got to do the right thing.
Yeah.
All right. So I didn't get to go to the presentation this morning. I was totally bummed out. But I stopped in for just a couple minutes, and I heard just some great questions in the couple minutes that I was there. So I'd love to hear a little bit more about the conversation that you all had during the presentation. Rick, can you think of one or two off the top of your head, and I'll go down the line?
Sure. So the gut one came up, is post-op nausea and vomiting the marker we need for gut perfusion? And that's sort of an interesting idea. Mm-hmm. We heard some questions about the data source and the methodology, and we worked through some of that. This is a sort of unique and very pragmatic source of data.
Yeah.
So there's some discussion around that and how the blood pressures got in and what they were. And
the magic 65 can't be right for everyone.
The magic 65 isn't right for everybody, so do we need to be precise or broad? Unintended consequences came up. Dr. London's excellent question about what's going to break if we fix it was the gist of his question.
And Dr. Sessler shared with us some late-breaking news, which will be reinforced at a session on Monday, was it?
Tuesday at about noon. 12:30, outcomes research.
Late-breaking news. I'd say the executive summary was that just fixing blood pressure doesn't fix the problems.
Yeah.
It's a much longer story, but there's nothing to suggest, including a very large recent study, that just addressing blood pressure is not making a big difference.
Yeah. We keep talking about on TopMedTalk, the concept of hemodynamic stability more than just fixing blood pressure.
Or the possibility that being in a large trial fixes the problem.
Right.
Yeah.
Regardless of where your blood pressure is.
When you look at it closely, I think one of the primary outcome variables was myocardial injury. And I think I've seen it presented 3 times now. I think it was a lot lower than expected. So you might be right, Rick. It might be being in the being in a study is good for you.
Yes.
So more grants, more studies.
Well, should argue for more attention.
Yeah.
Which, again, getting back to let's just fix it.
And ultimately, I do think that is kind of the crux of what we are talking about here, of the multifactorial. So while just treating blood pressure may not be the end-all, be-all, of fixing the end result. There is a increased heightened awareness, more sort of hands-on approach to managing that patient that kind of comes with that. That may, factor into having the patient come out better at the end.
Because while as we're going to move towards probably a team metric of some form, it's happening around the world. So when things are discussed everywhere you go, it's probably coming. And on the team metric, our contribution to that, one component of it is probably going to be something about hemodynamics.
Right.
It's probably going to be something about how we give the anesthetic. It's probably going to be something about how we relieve pain, morphine equivalents. But I think it's extremely unlikely that hemodynamics won't be in our team metric.
It's bound to be, because even though we can't prove that treating the hypotension treats all those major outcomes, we can't prove yet that treating it appropriately, whichever appropriate looks like, won't do that. So we may not know how to treat it appropriately. It's very fair to assume that proper management will lead to less adverse outcomes, which is where all looking at this from multiple angles comes in.
And taking the safety 2 approach, maybe we shouldn't be thinking about the pathophysiology. We should be going to Australia and saying, what are you doing?
Yes.
Right. Yeah.
How did you have 0 AKIs? What's different about that group than the rest of us?
That paper's under review at the moment, but you can get an insight into his attention to detail.
Right.
And almost all of it was post-operative hemodynamic instability, and the majority of interventions were a little bit of fluid and appropriate use of vasoactive agents. And it didn't just make a difference to the short-term things, it made a difference to length of stay,
Agreed.
staffing ratios, readmissions, everything you'd expect down the road.
Yeah.
So where are we going? What's the next steps for us, Josh? Walk us through a little bit.
Well, I mean,
Thoughts?
I don't want to jump to solutions. So I will say personally, putting on my quality hat, I have already started to kind of socialize this amongst our leaders at the organization to say, this is an issue. The data is very clear that intraoperative hypotension is bad and does cause and can contribute to end organ damage. We need to start adapting our practice to address this. As far as our broader sort of research goes, we would love to kind of incorporate a few more sites in it to sort of validate that 29% measures across other organizations as well.
Types of practices.
Exactly, other
like
types of practices. And then I think, I would really love to explore the ASC question a little bit further and see if it continues to be consistent with that population.
Now, the ASC results will be presented, I think, Rick, is that in a meeting coming up soon?
Yes.
We should say ASC is ambulatory surgery centers, which are growing in popularity, understandably, but...
I mean, hospitals, at least in the U.S., are just going to be, you go there, you get your procedure, you go home.
Yeah.
Or maybe you go there to die. And very little in between.
Okay.
And you think about wearable monitoring, home care. We know patients do much better in their own home than anywhere else. The whole world is going to be an ASC soon, I guess is the way to what I'm saying.
How are they going to bridge that? Because that Australian example, when they were letting people sleep it off on the floor, only 1 in 20 were prompting an alert that they needed some extra attention. When they kept them in recovery for 24 hours, it was 1 in 2 people. Mm-hmm. So are we all going to be at home trying to sleep off our problems and think we're getting away with it, or we're going to find a middle ground?
Right. So I was saying to you before is that the whole ASC concept kind of normalizes deviance, right? All these patients do fine. They're great when we leave. They must be fine. It must be okay. We need to fix that. We need to take the attitude we have about patients in the OR, PACU, under our care, in the intensive care unit, and extend that to every patient, even if they're recovering at home.
Because I'm cool going home, but in the same way as that, honey, you roll over, you're snoring. Little honey, your blood pressure's a bit low. We should do something about this.
Let's talk about something.
We'd be fine if we've got a solution for it. So,
the phone rings. Monty, go drink some Gatorade.
There we go.
Hi, this is the hospital calling.
Let's do it. Where are the results going to be presented soon, Rick? You organised for us to have
the postgraduate assembly. So New York Society of Anesthesiology, PGA meeting in New York City will be, the ASC data will present there.
Okay. And then later next year as well, this is something that we're hopefully going to be presenting at.
Right. We'll have a similar panel to today's at the IRS meeting,
Which is, what does that stand
International
for?
Anesthesia Research Society. That'll be in Denver in April. I think.
Yeah.
Yeah.
Yeah. So on the horizon, looking at like next steps for for this research group and looking at the data set or potential new data sets.
Yeah, I would. I'd say there's three big goals coming forward. One is the sort of straight line. Let's get into our big hospitals where we have good EMRs and can link data and try and connect outcomes to process. So this was the blood pressure. This was the creatinine. This was the blood pressure. This was the troponin. We're working on that. Then there's where I was, let's solve the problem before we know anymore. And can we introduce quality improvement innovations, something that this is a good group to do that, and lower the incidence, right? So we now have some very good baseline data about how often hypotension happens and in what populations. Can we fix that? Can I go nudge my partners and say this is bad and find ways to make less hypotension? That's one. And then the final one is the regulatory pathway, talking with Dr. Fleischer. Let's put some metrics on the table for both the hospitals, the teams, the doctors around this area, just to put more regulatory attention on it, which will inevitably bring some of these other changes.
Agreed.
So,
Yeah. Fantastic.
that's what I would say. But that's where we're headed.
In our spare time.
In our spare time.
Well, I mean, I will say, even personally, like when I am clinical, I have arranged my schedule such that when I'm clinical, I'm hands-on doing my own cases, and it has this has changed my practice, and that it's I'm going to dial back my gas a little bit. I'm going to crank up my fluids a little bit more and do what I can to manage before grabbing the purple stuff. But if we need to use the purple stuff, we will. And my willingness to tolerate a MAP of 62, of 58, or whatever in a healthy patient, it is not there anymore. I want to intervene and manage those patients a lot more tightly.
Which I think is going to be difficult going forward, because I know it is a drum that we've been beating, especially at some of our larger sites. So to get clean, there's never going to do a double blind study.
It's and maybe you never stopped, and it is now reasonably evidence based to carry on to do. Have you gone back to letting that first litre of Hartmann's run in around the time of induction of anaesthesia?
Yeah.
We always used to do that, was just baked into a normal anaesthetic.
Yep.
Somewhere someone stopped it without any evidence to stop it. And now we have the evidence to say, could you please start that again?
Exactly.
Yeah.
Exactly. Just let it roll.
Yeah, absolutely. Gentlemen, thank you.
Rick's looking, what evidence?
Probably not Hartmann's, right? I mean,
I wondered if actually
Dr. Johansson has told you that's bad for the endothelial glycocalyx, right? And there may be complications to that.
That's another interview for another day.
Different day.
Different topic.
What about Ringers then? Because he was the Brit, Hartmann was the American.
Yeah, same. It might not be crystalloid, and it might not be run it in fast. But
no, we're dribbling it in.
Okay.
Co-loading. We're co-loading.
Co-loading.
There we go.
I like that.
That's a term.
Yeah,
that's a term. That's why you leave it on the little IV and you let the whole bag run in without noticing. If you say that's co-loading. Yeah.
And there's a bit of evidence on that as
well.
Yeah.
The glycocalyx, let's go
Sorry.
there.
No, I love it. We should go down this rabbit hole again at some other time.
Yeah.
But gentlemen, thank you so much for everything that you're working on right now. It's been a pleasure to partner with this group and collaborate.
It has been fun.
It has been a lot of fun. And look forward to all the work that we're going to be doing in the future and sharing it really with, everyone in the world.
And see you in New York.
I won't see you in New York. Wael is going to be the NorthStar representative, and Rick will be the USA representative.
But maybe we'll be transmitting it so you can all see it in New York.
That'd be nice.
That'd be great.
They're going to sneak out of the presentation to go watch the Heisman Trophy.
That's happening at the same time.
Another good reason.
Is that a thing? Is that one of your World Series that only you can play in? Or something like that?
It's the real kind of football, Monty. I know, it's light. So this discussion about intraoperative hypotension, hemodynamics is something that we've been talking a lot about. TopMedTalk, we actually started it at Anesthesiology 2017. on TopMedTalk. So if you want more information, want to hear more conversations, TopMedTalk.com. You can find it there, or the live.ebpom.org site. Please do check out those conversations. You're going to hear more from this group, I promise. Thank you so much for listening. Thank you to our sponsors. We will be back. All right. Cheers. Thanks, everybody.
Thank you for having us.
Thanks.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.